Hello, everyone. Feel free to get settled in. We're just going to get started in about a second here. Make sure everyone's mics and cameras working if you like. Feel free to stay on or off camera. All right. So why don't we hop right in? So thank you for joining today's event, Black Representation in Basic and Translation Research, brought to you by CMC, the Changemakers Club of Canada. CMC is a grassroots membership-based incubator that brings together changemakers from across sectors to align their priorities, share strengths, and collaborate more effectively. Curated by Solutions for Life, it serves as the national home where leaders build trust and co-create solutions for meaningful social change. If you enjoy your experience here today, please consider requesting a membership at solutionsforyou.ca. Thank you again for joining. And now I'd like to pass it off to our host for today, Larry Afun. Larry?
Hi. Thank you so much, Eli, for the brief introduction. I will still introduce myself in a little bit more detail. My name is Larry Afu, and I will be the moderator for today's event. I'm a PhD student in neuroimmunology at the University of Toronto. I got my bachelor's in the same university, studying physiology and immunology. Right now, I study, very broadly speaking, what brain regions and why are they uniquely affected in diseases like MS and other brain injuries. Specifically looking at cells called oligodendrocytes that are famously impacted by diseases such as MS. I feel like I have a stake in this conversation because I was honestly floored the very first time I learned about how little has been done on the research front in terms of understanding the etiology of MS in people of African descent, and giving us that I'm a Ghanaian and thereby someone of African descent. I was incredibly interested in doing something about this problem. Uh, and I'll pass it off to Dr. Nathoo to
Sure.
introduce himself.
Thanks for having me. My name is Dr Nathoo. I'm a neurologist specializing in multiple sclerosis and a researcher at the University of Alberta. And my research interest, one of them, is in looking at diverse ethnicities with multiple sclerosis. So the context I'll give is MS, but we know that these issues kind of exist in other diseases as well. So I'll just start by very briefly presenting here. Just want to confirm you can see my screen.
Yes.
Perfect. Okay, thank you. So when we look at the people with MS in the world, if you look at this map from 2008, if you're in red, there's a very high prevalence of MS, which is in North America, and then kind of Western European countries. All the countries in white have no information. So if you look at most of the African countries in 2008, they have no information about the prevalence of MS. Then if we look 15 years later in 2023, it's a bit better in terms of African countries that can report on prevalence of MS, but all the countries in gray have no data. And this is the Atlas of MS. This is kind of the main way that we're able to see who's living with multiple sclerosis in the world. And as you can see, we don't have information for really the bulk of African countries. And in the Atlas of MS, they mention that low-income and African countries are often disadvantaged because it's hard to get to a diagnosis. They don't necessarily have MS specialists, and so they're likely underreporting the data that exists. So Larry and I were attending the first African MS conference on the weekend that was in Ghana. We were both on virtually. And so I was asked to speak about the epidemiology of MS in Africa. And as part of that, I went looking at kind of what exists outside of the Atlas of MS. So I'll just comment on a couple of things here. One is, because there's so little data in the Atlas of MS, others have kind of attempted other ways to obtain information about who's living with MS on the continent. And so this was a study done with a survey. So the survey was sent out to physicians in all of these African countries. They had, I think, 24 or 54 countries responded. And in every country that did respond, they reported cases of multiple sclerosis that had been diagnosed mostly within the last year. The problem is some of these places have neurologists, some don't. And then even if they have a neurologist, they don't necessarily have an MS specialist that can help with the diagnosis. But even looking at this map, you can see that there are countries that are reporting people with MS that are not seen in the Atlas of MS. And so this was kind of one way to get at the underreporting. And, in this paper, they did a nice job of trying to figure out, well, what are the limitations for us getting to a diagnosis? The main one actually they identified was cost of MRI, because it's over 100 USD. That a person living with MS is paying. And you can imagine these are low middle income countries, so they don't have the means to do that. And then actually having access to an MRI within a certain radius of each place. So access and cost of MRI were considered to be the major limitations. And this is important because our diagnosis of multiple sclerosis is increasingly reliant on MRI. So the last slide I have is on sub-Saharan African countries with publications on MS. So I didn't actually include the North African countries. There is data for Morocco, Libya, Tunisia, and Egypt. But all these countries in red are countries that I was able to find even a single case reported of multiple sclerosis. So all these other countries that are not outlined with a red box, other than North African countries, have no cases that I could find reported of MS. And this is interesting because I have, fortunately, funding from MS Canada to look at African, Caribbean, and Black people with MS in Alberta. And we actually have people in our study that's ongoing with MS from countries that are not encompassed on this map. So we have people from Eritrea, we have people from Namibia, we have people from Rwanda, and we have people from Benin. And so, all of this to say that there is a huge lack of data, and I should have included this actually, but we also don't do well with including these populations in clinical trials, and the medications for MS we use work differently in different populations. So I think there's an increasing recognition that this is important, but a lot of work still left to be done. So I will let Larry fire the questions and for the audience to do the same.
Right. Thank you so much, Nabila. Again, like every time I see the stats, I'm continuously astounded.
Yeah,
But I purposefully made this meeting a small one just because the couple of medical students here,
sure,
and there will be a law student as well joining in soon. But I did want them to introduce themselves
sure,
as well before we get in, just so you
sure.
can get acquainted with them. So if you will indulge me, we can start from Mr. Boateng. Can you introduce yourself and what you do and what you're studying?
Hi, good afternoon. So my name is Kwejo Boateng. I'm a student in Ghana, first year graduate entry student in Ghana here. I'm studying medicine, by the way, at Family Health University. Larry, Larry told me about this, I think about 2 months ago, and I'm very excited to be here. And yes, well, I can't wait, to ask the questions, and I can't wait to hear what Larry too has to say. Thank you so much for the opportunity.
Thank you. We can pass it off to Jillian.
Thank you very much. Hello, everyone. My name is Juliet Tako. I am a Ghanaian, but I'm currently in St. Vincent and the Grenadines, studying medicine at All Saints University. Thank you.
That's great. Liliana, do you mind introducing yourself?
Oh, hello. I'm a student practicing biomedical sciences in Florida.
Nice. Nice to meet you. Vladimir, do you mind introducing yourself?
Yes, hello everybody. I'm a senior scientist at University of Guelph. Came from doing research in multiple sclerosis, but now switch gears and studying Lyme disease.
Amazing. Thanks for introduction. Paul, do you mind introducing yourself?
Hey, everybody. My name's Paul D'Agostino. I'm a recent graduate from the University of Toronto, Life Science undergraduate degree. And I'm just really interested to learn about what's going to be presented today.
Right, great. Nice to meet you. Full disclosure, Paul is a very, very good friend, so I'm happy that he's here as well. Okay, so the way I'm envisioning this is that I want to do very little talking, but I am going to moderate. I have questions of my own. given that I'm incredibly interested in this kind of thing. But at any point, please, all of you, feel free to ask questions directed at Dr. Nathoo or myself. I imagine that I'll have much less to say than Dr. Nathoo, but okay, I'll kick us off with the very first question, which is that in your presentation, Dr. Nathoo, you mentioned that there's a diagnosis problem, and even the data that we have is based on people's survey. Sort of the limitations with surveys is that people are the ones supposed to report, or at least in this case, the physicians are the ones supposed to report the incidence of MS. Well, why do you think there is a difficulty in diagnosis? I know you mentioned the lack of MS specialists, but
Yeah.
is this a problem of training? Like, what is the key issue here?
Yeah, I think this is difficult. So the number of neurologists in each of these countries is super variable. So I'll just say, and Larry, you were there. So there's a neurologist that was at Johns Hopkins, who's now in North Carolina, and she actually moved her whole family to Zambia mid-career, which is Deanna Saylor, to basically create some neurology residency in Zambia. And so before, I think it was about 2018, they didn't have that set up. And so part of it is training. So now they have a robust neurology residency program. She is an MS specialist and researcher. And so what she's managed to do now, and the survey study is from her group. And so what she's managed to do now is, with the team obviously, is create research on the clinical characteristics of people in Zambia with multiple sclerosis and kind of related neuroimmunological disorder. So I think it's a few things. And I had a slide on this, but I will just talk about it because it's kind of technical and I don't think we necessarily need that. But one is training, right? So having enough neurologists and then having enough people trained as MS specialists. A lot of the people coming in with symptoms of MS are being initially seen by either a general practitioner or an ophthalmologist and then being referred to neurology. So one is training, two is delays to diagnosis because they have to see multiple people before it's recognized that maybe this could be multiple sclerosis. I think the other part is education, and part of this is just historical, right? Like all the textbooks when you're in medical training say, oh, actually, this is just a disease of people of European ancestry. And we know that that's not right anymore, right? And it's not, part of it might be because there is an increasing incidence, but I think the other part is just recognition that this actually does affect people from other places. And so they had looked at this in Southern California in terms of white American and African American, and actually the likelihood of having MS, the prevalence is the same between white American and African American in Southern California. And so, and that's one part of America, right? And as I've mentioned, like we have all these other countries in Africa where we have people that they've come and they live in Edmonton now and they have MS. In terms of other things with diagnosis, MRI access is another issue we mentioned. For the folks in the audience, we use cerebrospinal fluid or a spinal tap as part of the diagnosis for some people to kind of meet the diagnostic criteria for multiple sclerosis. And the kind of special testing that one needs is not necessarily available in all African countries or easy to obtain because you need some special training in order to be able to do that testing to look for findings that we would see in multiple sclerosis. So I think diagnosis is a hindrance because of many things, right? And I think the folks in these countries are working very hard to work around these issues. I do think training is probably amongst the most important, and there's a lot of work being done on trying to do virtual education as well for people in training so that they can get some expertise. And to be frank, like that's stuff that I'm also trying to work on my end is how can we share our expertise because we have so much and so many of us in Canada even that how do we help kind of facilitate the education for people in other places. So for the folks in Ghana, there's supposed to be Carl, who was at Africtrums, has spoken to a bunch of our neurologists, myself included, to do some education on neurology topics for your students in interested in neurology group or neuroscience group. right? And so I think these things are also helpful to get people interested in neurology, and then to have people also interested in multiple sclerosis along the way.
Yeah. Okay, so if anybody, you have to ask questions if you want to, because I have like rapid fire questions in my mind floating as rapid. So I will give a second to see if anybody has some questions, but I have some follow-ups as well. Okay, I'm just going to go for it. So Dr. Nathoo, I am
Hi.
incredibly
Hello.
yeah,
Yes.
please.
Hi.
Welcome you there.
As a medical student, right? Please, I wanted to ask that what advice would you give us, to those of us that are interested in maybe in the neurology and the multiple sclerosis research? What advice can you give to us, as medical students?
I think, yeah, it's a good question. And I will say I don't know the setup for neurology in each of the countries, so I'm naive there. But I think to express your interest to some of the people you're training with, some of the people you might be rotating through the hospital with, is helpful. The other is this arrangement of these seminars that Carl Hasford is starting, and I think a lot of this will all be on Zoom. And so I think once those things are available, you can see kind of what the different areas of neurology look like from some of us that will be speaking. And there is a bit more emphasis on global neurology, even at the American Academy of Neurology level. And so I think that would be a helpful exposure. And also, I'm here, right? So, so if you want like a contact, like I'm happy to have my email sent out, right? And to say like what I won't know how things specifically work in the country, but I think that if you're interested in neurology, I think that there's a huge benefit nowadays of having everything available virtually and online, right? And so a lot of things don't have to be done in person the same way for you to get a sense of like, what does neurology look like? Is this a career that would interest you? And then in terms of rotations, I think that's where I'm less well-versed for each of you, is what opportunities exist for you to rotate through neurology or shadow neurology in the hospital setting or in the outpatient clinic setting, so you get a feeling of whether it's something you like or not. Because I think that's the first thing, right? And then once you get a sense of I like it or I don't, then it's a matter of trying to figure out who offers a residency that you could do. Because I think most of neurology at this point is likely going to be practiced by internal medicine, right? And so there's this shift towards trying to make neurology its own residency in some places where it may not be. And I think there's an increasing need for neurologists now, right? It's amongst the most common and highest kind of morbidity diseases as per the World Health Organization.
Thank you so much.
No worries.
Dr. Nathoo, you mentioned I'm incredibly cynical about issues of getting more MRIs, especially in Ghana, for example. You mentioned that there's a combination of things people do to diagnose MS, namely spine taps, looking at CSF, some MRIs, and then in your previous slides, Afric trims, you mentioned like cell-based assays to do some diagnosis. I wonder if, given the predicament that most African countries find themselves in, do you think that if people have specific training in CBA and maybe reading MRI scans from other countries, that they may be better able to diagnose people, especially in light of these other family of demyelinating disease like MOGAD and NMO, for example?
Yeah. I guess you could be pessimistic about the MRI part. I think to get kind of regular field MRI is quite difficult, right? So 1.5 Tesla, I think, can be hard. I think this is where low field MRI comes in, right? And portable. And so these, and having kind of spoken with folks and companies in the US, like they have like a mobile MRI, so they can drive the MRI to a place. And although it's low field, thanks to technological advances that are happening very quickly, the quality of those scans has actually improved substantially, even in the last year. So I think that was one of the things I was proposing for Africtrums was, could this be helpful? Less costly. You don't need as much kind of the technical expertise. You don't have to have people from rural areas being forced to come to an urban area for a diagnosis. But again, I think with all of this, you still need a neurologist, right, who understands the clinical history and can perform the neurological examination and see, like, because you need to have a pretest probability before you send somebody for an MRI, right? And so I think the access to MRI is very helpful and very badly needed, but I also think you just need a neurologist who's going to think that this could be multiple sclerosis. And then with that is educating, and I think Frictrums did a very nice job of this, right? Educating people in each of these countries to say, well, actually, there is MS everywhere. And so we just need to have it on our radar a little bit more, maybe, right?
Right. And do you think, like, I don't know, when you look at a CSF, I don't know, maybe you're looking at IgG bands or something like that.
We are looking at oligoclonal bands. Yeah, that's right. Yeah.
Is that sufficient to give someone a diagnosis?
You need, so honestly, at this point, there's a heavy reliance on MRI. So especially with the newer diagnostic criteria, I think in the older ones, you could say, okay, 2 clinical attacks, but now there's a very heavy reliance on having an MRI, at least of the brain. So the cerebrospinal fluid findings are helpful to meet so for multiple sclerosis diagnosis for the audience, you need to have multiple sclerosis means multiple scars. You need to have multiple spots in the brain and or spinal cord. And we differentiate MS from other conditions with the location of the lesions or the scars and having these lesions come on over time. So the over time part, that criteria can be met with the CSF. And you are looking for the IgG bands, exactly. So you're looking for more in the cerebrospinal fluid as compared to the serum. And that does help you differentiate to some extent from the other conditions like MOGAD and NMOSD, because in those conditions, maybe about 15% of people will have the CSF findings of the bands, whereas kind of 85 to 90+% of people with multiple sclerosis will have those. So it's helpful in the diagnosis. When there's shifts in the diagnostic criteria, which can be helpful. So there are other ways of looking at the cerebrospinal fluids. And now we're looking at this thing called kappa-free light chain index. And you don't need as much technical expertise, and it can be done very quickly because you don't have to run all these blots at the same time as you do for the bands. But again, access to all of these tests, even for us, we don't have access to this kappa-free light chain test yet, the index, right? And so to say, okay, well, we should have this accessible to the African countries too, I think is going to be delayed. So still need MRI, unfortunately, and I think even more reliant on MRI now than we were before. So that's probably amongst the highest priorities.
Okay. I will give another second for anybody else to ask questions before I fire once more.
Don't be shy.
Yes, don't be shy. Maybe I should give some more time.
Yeah, I see. No, we got one.
Okay, that's good. Excellent. Whoever it is, do you mind? Nice.
Okay. Thank you very much. So I came across the expanded disability status scale, which I found out is used to measure the progression of MS. I would like if Dr. Nathoo could talk on it, and also if she could clarify if this is significant for people of Black descent, or it was specifically made to suit those of European descent.
Do you mind if I get you to repeat that part? So just because I've missed it. So your question about progression of MS in relation to?
In relation to the expanded disability status scale.
Oh, sure. So the EDSS, yeah, the expanded disability status scale. Yeah, good question. So so this is, and I think this is where we need more country-specific data too. So some studies have shown, so the African American population in the United States tends to have much more aggressive disease, and this expanded disability status scale, or this EDSS, is a scale we use in clinical practice and also in clinical trials to describe or put a number on the level of disability that someone has. So the higher the number, the more disabled they are. And cutoff of 6 we usually use as the indication that somebody needs a cane to walk, essentially. So in the studies in the US, the African American population will reach an EDSS of 6 faster than the white population. And they do tend to have more progressive disease. The difficulty with this is it doesn't necessarily apply to the African countries when they are doing their own studies. So, and this seems to be regional. So the Middle East, North African countries do tend to have more aggressive disease. They do tend to reach EDSS 6 sooner. Whereas some of the sub-Saharan African countries where we do have data, that's not entirely clear to us that that's the same trend. And if I look at kind of our data in Alberta, because we have a population of Middle East, North African, and people from sub-Saharan African countries, because our system is different here, we tend to diagnose people relatively quickly, even here, and then we put them on highly effective therapies for MS, and so they actually don't seem to be progressing faster when I look at our own cohort. And so for Juliet's question, I think it depends on the region, but I think the other part is are they having a delayed diagnosis? Because if you're delayed, you could have more clinical attacks, and then you could be accumulating disability, and your EDSS is worse, and then you are more prone to developing progression. Versus, yeah, if you're diagnosed sooner, put on drugs sooner, have drug access sooner, and this is actually where the diagnosis question is important for MS, but the other part is the treatment question. So if you've diagnosed people, what's the access to treatment? And that there's been a lot of work, and they have managed to add on 3 multiple sclerosis drugs onto the WHO's essential medicines list in the last couple of years. And actually that seems to have been very helpful for people to get access to drug. And so you can imagine you diagnose people earlier, you get access to drug earlier. The outcomes may not actually all be bad for everyone who is of Black African descent. So one is the meds, 2, and I'll just finish, Larry, and then you can interrupt me. But the second thing is the clinical trials inclusion, right? So the vast majority of clinical trials don't report on race or ethnicity in MS, and they've done a nice review of this looking at trials from 1995 till 2020. And then if they do report on race or ethnicity, the majority of those studies only report on white race or ethnicity. And so all the other groups are underrepresented in trials, and they're not even reported as being unique. And so there was one trial, it's a phase 4, so post already being FDA approved and being used, with one of the most effective drugs for MS. And now they have done a trial looking at people that are Latin American and Black African American, and I believe then this data was presented at a FRICTRUMS. They had 10 people from Kenya that were in the study, and they seem to do very well, and that's very reassuring. But we also, you want to have data for the people you're treating to be able to say, well, actually, these people were studied in clinical trial, and these are their outcomes, because some of the MS medications don't work as well in people that are Black African descent.
Oh, this is incredibly interesting, because if you are not putting them within the clinical trial, when you disseminate the medicine, you're doing an experiment which calls upon like some ethical considerations as well.
Yes.
I had a follow-up question with regards to that. Like at Africa Trims, I think you presented this, that something like 35% of Ghanaians who are diagnosed with MS are on any sort of therapies. The happy thing about that is that of those people who are on the treatment, they're on high efficacy treatment. Now, I don't know if the reason why the fraction of people treated is low is because we do not have these effective therapies available, or that people are not having access to them, or both. My question is if it's a matter of access, do you think like scaling back and using treatments like interferon beta, or maybe something more easily accessible like rituximab, is that a more practical approach instead of like waiting for high efficacy therapies to drop in our hands?
Yeah, and you're absolutely right. Those are the exact numbers. So, it's not clear to me actually, and I think that might have been a conference abstract. So the full paper would be useful, because the other question is it that people didn't want to go on therapy?
Oh.
Right? So part of it is access. Part of it is just, especially if people are feeling well, right? So multiple sclerosis is a bit of a tricky condition, because people can look and feel very well, but they have ongoing inflammation in the brain and the spinal cord. And until they're manifesting with clinical symptoms, they may not think that they need to be on a medication, right? So that part's not clear to me. I do think that the use of lower cost generic rituximab is a good one. And I think there seems to be a push towards that. The problem is that's still very expensive, right? So if people have to pay out of pocket, that's still very costly for them. And you can imagine that takes away the vast majority of their income. And so why would they spend it on that rather than on something else? So I think the subsidization of these medications would probably be very important. The lower efficacy medications are not necessarily going to be so much cheaper, I don't think. So that's a hard call. And the studies have shown generally that people of Black African descent do not respond as well to interferons. So I have not started anybody on an interferon. Well, also I haven't started anybody on an interferon for a while, but they don't tend to be as effective, and they have shown that in multiple studies. And so I would probably be spending more of my efforts advocating for use of high efficacy medication.
Right. This is interesting. I was also very saddened. One of the neurologists from Kenya mentioned that the government is no longer subsidizing ocrelizumab and rituximab,
Yeah.
and so this is incredibly annoying and sad, especially given that, for example, as you mentioned, interferon does not work well in people of black descent. Now, that sparks some ideas here because interferon, generally speaking, is supposed to be helpful for antiviral responses, amongst other things. I wonder if there's a relation here. We were talking last time off camera about how perhaps other infectious diseases might be part of the reason why people of African descent respond more aggressively, at least in the MENA regions, to MS. Is there some sort of relation here, or am I picking at straws?
It's a good question. Mechanistically, I don't know the answer. So, you know, Epstein-Barr virus and having had an EBV infection is kind of the most obvious risk factor for developing multiple sclerosis, right? And EBV infects the B cells. And so if you're taking away the B cells with these B cell depleting therapies like ocrelizumab and rituximab, these seem to be very effective. And I think as we talked about offline, if you've had infectious mononucleosis, which is the manifestation of EBV, if you are of Black African descent, you are much more likely to develop multiple sclerosis. Your odds ratio is higher. So compared to Latin American and white American in the study that had been done. So yeah, I don't really know the mechanistic reasons from the interferon standpoint. It's a good thought. But, and as we also talked about offline, because this was part of the basic translational research part of this discussion is, so for the audience, our most effective therapies for multiple sclerosis take away your B cells. They're B cell depleting therapies. And they're very, very effective. Very few people will have relapses or new lesions on the MRI on these therapies. I was going somewhere with this. Oh, yes. It has been shown that people of Black African descent that are healthy have higher numbers of B cells in general compared to people that are white. And so if you, even from a drug standpoint, like if you're putting everybody on this therapy that's given every 6 months, we are assuming that everybody's going to have the same response because they're all coming in with similar numbers of B cells. And that's actually just not true, right? And so even in terms of work on MS treatment right now, we're talking about extending the interval of dosing for people on these B cell depleting therapies because you're going to be on it for a long time. We want to kind of weigh out the risks and benefits of making your immune system very, very depleted over decades. And so the effect of the drugs tends to be longer than 6 months. So you could push out to 9 months or 12 months. And there's nice work that's been done with rituximab to show that actually this is effective and this works, and people don't tend to get new disease activity. But is that going to apply for the Black African population? Not necessarily.
That's an important question.
Yeah.
Oh my God. I'm gonna give some space for others to tie in before I do again. Is there anybody who has any pressing questions for Dr. Nathoo? Okay, I'm gonna go with my
Sorry?
oh, speak up,
Can
please.
you
Oh,
hear
go
me?
for it. Yeah.
Mm.
Yeah, so please, I was wondering from your experience, please, what are some of the most common misconceptions about multiple sclerosis that healthcare professionals still encounter, either among the patients or even within the healthcare community?
Yeah, honestly, even here, lack of recognition that this could be multiple sclerosis in somebody that's non-white.
Mm.
It's very even where I live, which is, one of the more diverse cities in Canada. I have had my own patients come in and talk to me and say, I had to go to multiple emergency departments. They thought I had a pinched nerve, and they didn't think that I could have multiple sclerosis. And I think it's worse from an intersectionality standpoint of being a woman who's racialized. And that's been anecdotally the most common description I've had. I think it's just people don't think that this affects people that are not of European ancestry. And so a lot of this is education. And so if I do end up in these situations where I maybe know who was involved, I have made a phone call and said, by the way, like this is actually seen in people that are non-white, and we need to put this on our radar, right? I would say that's the most common misconception or kind of miseducation is people don't think, they don't even put it on their radar. And so if you don't think about it, well, then you're not doing the test to come get to a diagnosis, right? And then these people are unfortunately just kind of sent out into the community, and it's like personal advocacy for the patient to have to come keep presenting to different places
Right.
until somebody can see that they are actually affected and orders the appropriate tests or gets the appropriate consultation. And in some of these situations, unfortunately, it's to the point where maybe the neurologist wasn't even called, right? So if we don't know about them and we can't even assess them, because if we come in, like we have an understanding, especially here, I work on this, so I've been quite vocal about it. And so, I think we're pretty good at trying to obtain the history and see, well, does this fit with a certain condition? And, if multiple sclerosis will often end up on that list of things. And so, but if you're not called as the neurologist, then you can't get involved to try to get to a diagnosis, right? So I think that would be the most common misconception, which is why we have chats like this, right? To say, well, actually, this is in every African country that has responded to a survey has multiple sclerosis in it.
Yeah. All right. Thank you. Thank you so much. Thank you.
Yeah, Dr. Nathoo, this point about intersectionality, I remember reading one of your papers some time ago where I believe you report that women of African descent, or certainly of that were African American, had like higher brain atrophy when they had MS as compared to their white counterparts.
Yeah.
I keep wondering about if there is a relevant distinction between uh, people of African descent, Africans, and then African Americans. Is this
Yes.
does the data translate to all of them?
No, what a good question. So, and I think this would probably stem from the first paper we did, and this gives me a nice opportunity. Thank you. So, so for the group here, so I did my MS training in Minnesota at the Mayo Clinic. This is a relevant discussion. So Minnesota has the highest number of people that are Somali outside of Africa. They have 86,000 Somalis living in the state of Minnesota in the US. And so when I was in training there for MS, I'd already been interested in looking at diverse ethnicities with multiple sclerosis. And so my mentor there said, well, we follow people who are Somali with MS. Like, what do we know about them? Well, we didn't know anything. There was one case reported prior. And so what we did was we looked at people of Somali descent, some of whom were born in Somalia, a few of whom were born in the United States. And then we looked at African Americans, and then we looked at white Americans. And comparing all three, the Somali group had MS onset at a significantly younger age than the white and younger compared to the African American, but their disease didn't seem to be more aggressive. So they weren't more likely, as Juliet had asked about, they weren't more likely or developing EDSS6 faster, so they didn't need a cane as early, but the African Americans did. And that's very consistent across the United States literature, unfortunately. So they tend to have more aggressive disease. They tend to have more progressive MS. But then the Somali group didn't have that. And so I do think that there are distinctions. And actually, this is one of the messages of the paper, right? Being Black means many things. It doesn't mean we shouldn't even be grouping them all together, right, for every study. Because where you're from, what environmental risk factors you might have had, some component of genetics, those things all affect your risk of getting an MS diagnosis and then your prognosis, essentially. So I think we have to be actually quite careful and separate the groups in terms of where people are coming from, because the outcomes seem to be different. And the African Americans having more aggressive disease and unfortunately having worse outcomes is very well documented throughout the US. Whereas if you look at other countries, and so the healthcare systems, I think, matter here. If I look at our data and if I look at the UK's data, the people of diverse ethnicities don't seem to have worse outcomes yet, right? And these are large studies, especially from the UK. So I think that was published within the last 2 years, and they have, like, I think they had over 1,000 people, and they have a lot of South Asians in their cohort. They had younger age at onset, but they also didn't seem to have more aggressive disease. And so is it the access to care, access to getting diagnosed, access to drug that could be different in terms of the outcomes for people? So in terms of your question, so yes, intersectionality, so you're right. In that study, the Black women did have more atrophy of the brain and upper cervical spinal cord, and they were African American. So that's exactly who we included. We didn't include the Somalis in that study because there were so few. But the African American women did have more atrophy, so smaller brain volumes and smaller spinal cord volumes. But and they didn't have more aggressive disease clinically at that time, right? And so you kind of worry, is this going to be a risk factor for them down the road to have progression or to have, disability accumulation?
Right. This is incredibly interesting. Sometimes I wonder if there's something for the gut diet or stuff like that. You know how emerging evidence, even Dr. Gomerman and Olga Rojas at some point showed that IgA B cells trained in the gut can release IL-10 and have an anti-inflammatory response, at least in our mice models of MS. So sometimes I wonder if the differences between the different racial groups can be explained away by
I think some of it will.
diet.
Some of it will. So in our Somali, African American, white American study, we looked at BMI, and the BMI was kind of closest to healthy in the Somali group, furthest from healthy in the African American group. And then we also had vitamin D data. And so I think in terms of, so vitamin D deficiency is a risk factor for developing multiple sclerosis. And the African American group had the lowest vitamin D levels. Somali was in the middle, and then white was highest. So I think these factors are certainly important and actually become a point of discussion, because if you're coming from an African country and living now in Canada, you're taking on the Western diet, you're taking on these ways of living, and so they are at higher risk of developing medical comorbidities like diabetes, high blood pressure, high cholesterol, and those things also make MS worse. So these are things for us to keep an eye on for sure. I see a hand.
Yes, please go for it.
Yeah, good morning. Thanks again for the conversation. Really interesting. And you just made I was just interested in your point about the gut and how it has some implication when it comes to MS. Recently, I've been reading a lot of articles on fiber intake, and again, it might just be more of a cultural thing, but recently there's a lot of correlation between fiber and autoimmune diseases such as MS, and people who take a lot of fiber, that is food for the gut microbiome, right? So you're increasing the population of good bacteria in your gut, and then hence reducing like all the inflammation, like the leaky gut and all of that. And yeah, I don't know if you guys have seen, if there's anything that you guys know about that, but I've been seeing a lot of correlation documentation about gut health, which is related to fiber intake. Thank you.
Interesting.
Thank you.
I don't know that much about this, I will say. I think that kind of rationale makes sense to me, right? in terms of the diet discussion, the thing we usually recommend to people is to be on a Mediterranean style diet, because that reduces your chance of these other comorbidities, right? So basically it's like heart health, cerebrovascular health, and those things positively impact MS if you're doing kind of those things well and have a healthy diet, if you will, and kind of a Mediterranean style diet. And that would include a decent amount of fiber, I would say. So the specific mechanistic stuff, I will say I don't know, but I think that the switch in diets, even for people when they're moving from African countries where they're having a much healthier diet there and then coming here and having, lower fiber diets and less healthy diets, I think is certainly a risk factor for the multiple sclerosis as well.
This is interesting. It's counterintuitive though, because the MENA group, presumably they are on Mediterranean diets, have also more aggressive forms of
They
disease.
do.
So
And I
hard to
don't have an
square.
explanation for them. Even their, yeah, really, truly. And even their cohort that they published on, 75% of them were on disease-modifying therapy. And whether they were high or low efficacy, that I don't recall. But they also had a bunch of people that were treated. And then anecdotally, even here, they can have quite aggressive disease when we see them and they're quite young. And so again, not clear why. And there has to be, I would argue, some combination of genetics and environment. That's the factor. But what that specifically looks like is not clear at this point in time.
Absolutely.
Yeah, and then
I open it. Yeah,
one more
no, please
last
go ahead.
question. So
Please, yeah.
my background is cell and gene therapy. So
Okay.
yeah, so do you guys see any correlation when it comes to, like, I know again there are so many therapies out there for like different cancers, for Parkinson's, maybe stem cell related complications. But when you look at autoimmune diseases, do you see are there is there any information out there that cell and gene therapy can help with MS?
Yeah, so there's an ongoing trial now that has started with CAR T
Okay.
for CD19.
Perfect.
And so
Okay.
some of the initial, I think the first patient was done at Stanford, and Jeffrey Dunn will have an article of sorts on this, I believe. So CAR T is very hot for MS. As a hot area. And then I believe the same kind of CAR T CD19 is also being explored in lupus. So certainly moving in that direction. Who they have included, in terms of reflecting the population living with multiple sclerosis, it's very expensive, and this is quite new, but it is very, very exciting because this is felt by some to potentially be a cure. Right? Like you get the CAR T, you're done. You don't need more treatment. So I think to be determined on that.
Yeah.
Okay. I think CAR Ts are incredibly cool. Dr. Nabila, could you expand on what the CAR Ts are just for the audience?
I don't have a lot of experience with this, but essentially you're taking kind of the patient's own immune T cells, you're kind of taking away certain components and then giving them back. And they're kind of focused on CD19 because this is B cells. And so this has kind of been demonstrated to be a significant pathogenic contributor to multiple sclerosis. So re-engineering those and then giving them back, basically, is my kind of very general understanding of somebody that doesn't work in this, but reprogramming the B cells.
Yeah, that's pretty much what CAR T is. There's also that what you mentioned is more of autologous CAR T, whereas that same patient, samples from that patient is reprogrammed, activated, transduced, and put back into the patient.
There you go.
But there's also what you call allogenic CAR T,
Yeah.
where you're taking like a healthy donor and then you're producing therapy that will be able to dose as many people, like pretty much off the shelf.
Right. So for the MS standpoint, it's very few that are in this for a trial, and I believe it's autologous for this one.
I see.
Yeah.
Yes.
Eli, could you go ahead?
Yeah.
Yeah, thank you for this riveting conversation so far. I will say, though, that I'm a political scientist, so I figured I'd ask a politics-related question.
sure.
Just squeeze one in here. So, first of all, I also wanted to shout out a book, Rethinking Global Health Frameworks of Power, Rochelle Burgess, released it in 2023. Doesn't get into MS, but it gets into a lot of health related inequities and how it kind of works on a global scale. But my question more specifically is kind of related to, again, I'm not a scientist in the way that you guys are, so some of this is more technical, but one of the things me and Larry, for example, can agree on is that there's clearly kind of this kind of racial inequity kind of happening to create these more medical inequities, right? And I was wondering if you can kind of, maybe from your perspective, what are the more like political power related dynamics that continues or perpetuates this pattern of underdiagnosing Black patients, again, their absence in medical trials and things of that nature. And do you see like any shift that may point to not just a medical better future, but maybe a political better future where some of these medical things kind of rely on political decisions made by governments and people of that nature. So just wondering any of your thoughts, if you've thought about it in this way, and how you think it's going to go forward in the future. Thank you.
No worries. You asked the controversial question at the very end, hey? Oh, this is so hard. I think the difficult aspect in all of these discussions is companies, etc., are chasing where money is, and that really doesn't exist in these low middle income countries in Africa. And so and I'm sure many others have been in discussion with these companies about the reality that people are living with MS in these countries, and we need to find ways to offer them treatment. I think the political landscape and the interactions between countries very much impacts all of healthcare, and then this is just a downstream effect of this. So a lot of the work, even from looking at Africtrums, was people are trying to do things from the ground up, right? So you're trying to establish like, okay, there is MS here. We are seeing it. How do we advocate for our populations? And then I guess in summation, like, can we make the health of the country better? But this is where I'm a bit less optimistic right now, to be honest, is I think the political climate is as such right now. There's Ebola, and how that is playing out is a whole separate conversation, very much offline. But I think you see that there's still this constant fear of things going on in Africa and less help than they need, and then still taking of resources. And so for fear of saying too much, I will say I think this is a very strong influencer of the healthcare outcomes, and kind of the blind eye that's been turned in my own field of neurology and multiple sclerosis to African countries, to other low middle income countries. And this is why I kind of feel, and I said this at Africtrums, like I think we kind of have an obligation as the privileged to shine a light on, okay, well, actually, you do have this disease in all these countries, and to try to lend a helping hand to raise awareness. And then through that, like, the reality is in this specific field, and I'm kind of answering your question, but not Eli, so I'm sorry. But the reality is you can't fight for something if you haven't said that it exists somewhere. And so I think that's always been step one, right? And this is the kind of grassroots work that everyone's been doing that was beautifully presented at Africtrums. And then this is what we're trying to do here, to say, well, we're going to complement the data that you're getting in your African countries to actually say, actually, there's MS everywhere. Why aren't we doing something about this? Right? So I guess I think of it from like a very low level. And I am often dismayed by the political climate that we're trying to work this through. And so I think awareness is number one and advocacy for these populations. And the reality is, as many of us on this call, if we're in Canada, we all come from other places. And so we have the privilege to be able to speak up and say, what are we doing to the people that are higher up? But we also need more people of diverse backgrounds in leadership, right? To push the agenda. It's kind of a half answer, Eli. I'm sorry.
Just to piggyback on what Dr.
Mm,
Nabila, right?
Yeah,
Nabila,
yeah.
yeah. So it's very interesting because being in the cell and gene therapy space, big pharma, everything is about money, right? It's about money, it's about resources. And also, you mentioned, I think education is very important. I think people from particular communities, they still feel that some of these diseases is non-existent.
Mhm.
There is non-acceptance of it, and we need to do better to start sharing light on that. For example, see what COVID did. COVID made Africa feel like we can't depend on our own selves. We're so dependent on the West. And right now in Africa, Africa is trying to be about they're trying to get to a point where they can produce 60% of their own vaccines. Maybe at that point, taking their own vaccines being developed in their continent is going to be they're going to be more comfortable, right? Because again, another thing is a stereotype about taking vaccines from the West and bringing it to Africa. It's a lot like we grew up knowing that, right? But right now you can see a shift where there's a lot of talk about manufacturing, biomanufacturing of basic common vaccines in the continent. So that will go a long way to kind of like alleviate some of these stereotypes. Yeah.
Yeah.
Amazing, well said. When Dr. Nabila ended with the idea that sometimes if you do not name the problem, it will not be solved. The philosophers call this sort of epistemic injustice, where if you do not clearly couch the problem in words, it risks being forgotten. This is particularly relevant in like abuses that were levied upon women in the past because there was no terminology for what was happening. The women would report that they didn't even know it was a problem at all. And I think that's an important place to end off. I do want to ask one important question at the risk of going over time, that we know, especially in Ghana, there's a huge problem of superstitious beliefs, especially when it comes to things of medicine. And Dr. Nathoo, you mentioned before that it may be possible that the reason why there's only 35% of people on effective DMTs is because they might not even want to take these drugs in the first place. I just wonder if you have any words of wisdom for how you interact with your patients when they have
Yeah.
a strong superstitious beliefs in
Yeah,
the
I have a
opposite
lot of
direction.
South Asians with this too in my
Interesting.
practice. And so, and they'll say, like, I had these symptoms and I went to see an alternative medicine provider and then I
Mm,
was cured. And it's like, actually, that's just the general timeline of how the clinical attack would resolve. It's often repeated conversation.
mm,
And, then I had the advantage of getting to show them their MRI.
mm,
So I
mhm,
go through that, frankly, with everyone, but over a lot more time to explain, like, this spot in your spine may have caused these symptoms you've had. And that doesn't fit with, an alternative explanation. And these scars are there and they're unfortunately there to stay. And so I think it's a lot of more back and forth and kind of going back even to their history. Some of these people have had their symptom onset in India. I'm sure people have had theirs in Ghana, and then they come. And so going through that and saying, well, like, all of this actually, what you've had for 10 years, this actually fits with multiple
mm.
sclerosis, right? And I think there's resources coming, so not to be a huge pessimist, but and actually I'm going to throw this link in because it was really
Mm.
interesting to me. There is, for MS Canada, they have now developed, oh my goodness, I'm gonna have to find this in my email. They have now developed a support group for people that are of diverse backgrounds. They've called it BIPOC. as their MS support group for people that are diverse living with multiple sclerosis. Because often the problem becomes when people come in, they'll say, well, I don't know anybody with this. I've never heard of this. There's nobody in my community that's ever had this. And it's like, actually, I have people in my study that all have this, that are all from your country. And so I think this MS Canada support group will give people the opportunity to, let's see if I can find it, to give people the opportunity to be able to connect with others who are also living with MS, who are of the same kind of background as them. I can't find it. If I do, Larry, I'll send it to you. But
yes,
yes,
I
think that interaction also is helpful.
Right. No, that's completely right. I'll be sure to send it to the resource to all the others in the call. I do not want to take Dr. Nathoo's time any further. Clearly a busy person. I do want to say a huge thank you to you and Eli for making this possible. I am completely humbled and floored that you made the time here, and I know that I'm constantly thinking about this problem, even as a lowly undergraduate student in Edmonton until now. I do want to have us to have some follow-up discussions offline, because I'm trying to start the conversation in Ghana about how we can better address these kinds of problems, and I'm sure you might be interested in helping in this regard. But with that,
sorry, Larry, I'll
yeah.
just quickly say nothing about you is lowly, so please don't put those two words together.
Nothing. Yeah.
Nothing. But go ahead.
Thanks so much for having me.
Yeah. Thank you so much. I had so much fun, and I hope all of you did as well. And so I will let Dr. Nathoo go, and if there's any sort of debrief, Eli and I, we can have it after you leave as well. Thank you so much.
Okay, thank you. Okay, bye.
Thank you, Dr. Nathoo. Thanks, everyone. Thanks for joining the call.
Thank you guys so much. Bye.
Yes. Thank you guys for making it. I really, really appreciate it, and I hope you learned as much as I did. Okay.
Thank you so much, Larry. Have a nice day. Bye.
Yes. Yes, we will connect on LinkedIn. I will send